Hello everyone and welcome. Today we're going to tackle a really important topic in pharmacology, antipsychotic drugs. Now I know this chapter can feel a little heavy, but don't worry, my job is to simplify it for you. We're going to look at the two main generations of these drugs, and I promise, by the end of this, you'll really understand how they work, how they're different, and why choosing the right one is so important for our patients.
So let's start with the most basic question, the one every single doctor has to ask. How do we help a patient with a deeply troubled mind without accidentally creating a whole new set of problems? You see, this is the tightrope we walk in psychopharmacology. It's a delicate balance, so let's start to unpack this puzzle.
First up, let's frame our discussion. We'll call this section the antipsychotic puzzle.
Okay, first things first, a basic definition. What are we actually talking about? Antipsychotics, and you'll also hear them called neuroleptics, are drugs we use for serious functional psychoses, with schizophrenia being the classic example. The goal is straightforward. We want to relieve the patient's symptoms and help them get back to their life. But, and this is the important part, these drugs don't just work on the brain. And that's where the puzzle really begins.
Now, look at this slide carefully because this is key. These drugs are systemic, meaning they affect the whole body. They can hit the cardiovascular system, causing things like postural hypotension. You know, that dizziness you get when you stand up too fast? Yeah, that. They can affect the endocrine system by increasing prolactin. They can also mess with a person's metabolism and, of course, cause a lot of drowsiness in the central nervous system. So please remember, we're dealing with powerful agents that have effects far beyond just the brain.
Right, let's move on to our second part. Let's talk about the first players in the game. First generation, the originals. This first group, the ones who really started it all, we call them the typical antipsychotics. It's a simple name to remember. They are the typical or classic ones.
So how do they work? Well, it's all about one main action, a very strong, very potent blockade of the dopamine D2 receptors in the brain. Now, this is great for treating the positive symptoms of psychosis, things like hallucinations and delusions, but, and this is the huge trade-off, this same powerful action is what causes their most notorious side effects, especially the movement-related ones. A classic example you will see all the time is the drug haloperidol.
Because of all those difficult side effects, researchers knew they had to find a better way. And this need for something new leads us directly to our third section, second generation, a new approach.
So if the first group was called typical, it only makes sense that this newer group is called the atypical antipsychotics. And they are atypical for a good reason. They're trying to achieve the same result, but through a different mechanism, one that was specifically designed to avoid the problems of the originals.
Their mechanism is a bit more clever, you see. They still block D2 receptors, but they do it more weakly. The real magic, the key difference, is that they also strongly block another receptor, the serotonin 5H2 receptor. This dual action is what makes them special. This combination helps to reduce those motor side effects and also makes them more effective against the negative symptoms of schizophrenia, like apathy or emotional flatness.
This table here really spells out the choice a doctor has to make. It's perfect. Just look. You have haloperidol, atypical. The risk of those movement problems, the extrapyramidal side effects, is very high. See the 3+ signs? But its effect on metabolism is low. Now compare that with olanzapine, an atypical. The risk of movement problems is minimal, but its sedative and metabolic effects are much higher. Do you see it? It's a trade-off. You're always balancing different risks for each individual patient.
Which, of course, brings us to our next section, where we'll look at this more closely, the side effects trade-off.
So, let's just summarize the main choice here. With the typical antipsychotics, your biggest worry is going to be movement issues. We call them extrapyramidal side effects, or EPS for short, and they come from that strong D2 blockade. With the atypical antipsychotics, your main worry shifts completely. Now you're looking out for metabolic problems, things like major weight gain, high blood sugar, and high triglycerides. It's a choice between two totally different kinds of potential problems.
Okay, everyone, focus up because this slide is very high yield for your exams. You need to know this. The extrapyramidal side effects from the typicals don't just happen randomly. There's a timeline. First, within hours or days, you can get acute dystonia. These are painful muscle spasms. Then within weeks, you might see akathisia, a terrible inner restlessness. Weeks to months later, you can see drug-induced Parkinsonism. And the one we fear the most, after years of use, is tardive dyskinesia, these involuntary movements that can become permanent. This timeline is absolutely essential to remember.
Okay, so with all this knowledge, how does a doctor actually decide what to prescribe? This brings us to our final and most practical section, choosing the right tool. This is where all that theory becomes real. The choice depends entirely on the patient in front of you. If you have a patient who is very agitated, maybe even violent, and you need to calm them quickly, a typical like haloperidol is a very common choice. If your main goal is to treat the negative symptoms, then you're going to lean towards an atypical like olanzapine or clozapine. If the top priority is avoiding movement side effects, then the choice is easy. You pick any atypical. And for those very difficult cases for treatment-resistant schizophrenia, clozapine is still our gold standard. And of course, just to round out the picture, it's not only about schizophrenia. For other conditions like acute mania or bipolar disorder, our treatment options expand. We often use antipsychotics, yes, but usually alongside other drugs like mood stabilizers, the classic one is lithium, or anticonvulsants like valproates. It's very often a combination therapy. So what is the final message here? The ultimate takeaway is that treating psychosis is an incredibly delicate balancing act. It's a constant weighing of the benefits of a drug against its potential harms. The whole story of moving from the first generation to the second generation is a perfect example of this trade-off. And it leaves us with a really important question for the future. What will the next breakthrough be? What will the third generation of these drugs look like? The challenge and the hope is to finally find that drug that gives us all of the benefit with none of the burden.
Good morning, bachcho. Settle down, please. Welcome back to our pharmacology class. So, today we are continuing with Chapter 32, and we're going to talk about a very important topic, the drugs we use to treat mania. We'll look at the old soldier, the veteran treatment, and also the new kids on the block that have really changed things.
So, what is on the menu for today? Here's our plan. First, we need to understand mania itself. What is the enemy we are fighting? Then, we will meet the old champion, lithium, our gold standard. After that, we'll see why using it is such a tricky, delicate balancing act. Then, of course, we'll look at the modern, newer options. And finally, just for interest, we'll take a quick peek at a totally different class of drugs, the hallucinogens. Cello, let's begin.
Right, first things first. Before we can talk about the medicines, we have to properly understand the disease, isn't it? If we want to treat mania, we need a very clear picture of what we're actually up against. You must know your target.
So, what is this acute mania? See, it's not just about being very happy. It's an inappropriate cheerfulness, or sometimes extreme irritability. The person has so much energy, they are restless, they can't sit still, they talk nonstop. Their thoughts are racing so fast we call it a flight of ideas. And sleep, they feel they don't need it at all. In the worst cases, this can go so far that the person, well, they completely lose contact with reality. This is the clinical picture we're trying to control.
Okay, so for many, many decades, our number one weapon in this fight has been a simple element, lithium. He is the veteran, you can say, the foundational drug for treating bipolar disorder and mania. So let's find out how it works and why it's still so important.
So let's follow lithium's journey inside the body. It's absorbed very well when taken as a tablet, no problem there. It spreads throughout the body's water. But now, look at point 3. This is the kicker. It is not metabolized at all. The body doesn't change it, doesn't break it down, and then how does it get out? Through the kidneys. And here is the most important clinical point for you to remember. The kidney treats lithium exactly like it treats sodium, Na+. This is vital because anything that changes the body's sodium balance, like dehydration or other drugs, will directly change the lithium levels. You must never forget this.
And that special relationship with sodium brings us to the biggest problem with lithium. Using this drug is not simple. It's like walking a tightrope, a constant balancing act. And that is why monitoring the patient, checking their blood, is absolutely non-negotiable. To bring an acute manic episode under control, the patient's blood needs to have a very specific amount of lithium. We're talking about a very precise range, 0.8 to 1.2 milliequivalents per liter. It has to be in this window, not more, not less. This is our target.
But now, look at this. The moment that level just creeps up a tiny bit to above 1.5, we are in the danger zone. Toxicity starts. The gap between a helpful dose and a poisonous dose is incredibly, incredibly small.
So this is the main point. Lithium has what we call a very narrow margin of safety, or you can say a narrow therapeutic index. Now, this isn't just a phrase for your exams. For the patient, it means regular blood tests again and again. For you as the doctor, it means you have to be constantly watchful, carefully adjusting the dose. It's a very involved process. Here is a perfect clinical example of this. A patient on lithium might complain that their hands are shaking a little bit, a fine tremor.
This can be a normal side effect, okay? But if you see coarse tremors, big, shaky movements, that is a huge red flag. It is a sign that the lithium levels are rising into the toxic range. Differentiating between these two is a critical skill for you in the wards. And besides tremors, even at safe levels, patients can have other problems. Feeling sick, feeling thirsty all the time, needing to pass urine frequently. These are common. Some people gain weight, and in about 4% of patients, it can even cause a goiter. We must tell our patients all this is possible so they understand and continue the treatment.
And the balancing act gets even trickier. Very common medicines, like diuretics for blood pressure, or even simple painkillers like NSAIDs, these can make the body hold on to lithium. They stop it from being excreted. And what happens then? The level goes up, 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 towards toxicity. This is why a complete medication history is essential before you even think of starting a patient on lithium.
Now, with all these difficulties with lithium, do you think pharmacology just stopped there? Of course not. So let's move on to the modern alternatives, the newcomers who have really changed how we manage mania today. So why did we even need these newcomers? Well, because of this number. Roughly 30% of patients, that's almost 1 in every 3 patients who either don't respond to lithium or they just can't tolerate the side effects and all the blood tests. This was a big clinical problem that needed a solution. So enter sodium valproate. Interestingly, this was originally a drug for epilepsy, but now it's also a first-line treatment for mania. And just look at the advantages. It works faster than lithium, and very importantly, it has a much better safety profile, a much wider therapeutic window. Plus, it's also very good at preventing future episodes, as a prophylactic.
And we have more tools in our box than just valproate. There is carbamazepine. It's an option, but maybe not as good in an acute attack. Lamotrigine is excellent for preventing the depressive phases of bipolar disorder. And, a very big deal these days, the atypical antipsychotics. Drugs like olanzapine, risperidone, aripiprazole. These have now also become first-line drugs for acute mania, often because they work quickly and are well tolerated.
Okay, now let's shift gears completely for a moment. This chapter also briefly covers another fascinating group of drugs, the hallucinogens. Now, these are not used for treating mania, okay? But studying them gives us a fascinating look into just how much a chemical can alter how the brain functions.
So, what are they? The technical term is psychotomimetics because they can mimic psychosis. Basically, these are drugs that completely change a person's reality. They mess with mood, thoughts, and perception, creating an experience that can be similar to a psychotic state.
Now, this is a very diverse group, so this table helps to organize them. You have indolamines, like LSD, and psilocybin, which comes from mushrooms. You have phenylalkylamines, like mescaline from a cactus, or MDMA. Then there are the purely synthetic ones, like ketamine, and of course the cannabinoids, with THC from cannabis being the most famous. Different classes, different sources, all with profound effects on the mind.
So, to wrap up, we've seen the journey of treatment for mania, from the old veteran lithium, with all its power and its danger, to the newer, safer alternatives that have given us so many more options. We also touched upon the very different world of hallucinogens. But the human mind is still the most complex thing we know. So the question I want to leave you with is this: what's next? What new tools will pharmacology create to treat these incredibly complex conditions of the mind? Think about that. Thank you, class.